Thanks. As was mentioned, Linda and I are with the Trauma Center, Southern Illinois Trauma Center. It sounds like I'm echoing quite a bit. Maybe I'll do that. Okay, sorry. And I will explain a little bit more what the Trauma Center is in a few minutes. We always start off in medicine, we give a talk, our disclosures. People worry about, who's paying their physicians, what are they doing, do we look like NASCAR drivers? I am on the board of directors for the blood bank that is centered here in Springfield. That is completely voluntary. I get no money. There's no finance. So like the more blood we transfuse, I don't get a check or anything like that. In fact, we try to get less blood used. But we do have to disclose that. We also have to disclose, being a trauma center, that we are sponsored by testosterone, with 55% of our patients being males doing various interesting things to help keep us going. So what we're going to do, Linda and I are going to go a little back and forth here for you. And we have a couple scenarios of kind of situations that may result in head injuries. Obviously, we can't get into every possible thing that can happen. We're going to talk a little bit about, what those scenarios are, what you would think when you're showing up in the field, the initial responders, which is Linda's expertise, a little bit more about what we think when the patient arrives in the hospital, and then some ways you can keep yourself from becoming a head injury victim. So our first scenario is a 16-year-old woman who was playing soccer, and there was a collision on the field. She was known to just fall down and go limp. Then she's groggy. She doesn't know what happened. She doesn't know the score. She doesn't know where she is, but like every athlete, she wants to go back in the game to help her team out. She probably doesn't even know which way to go if she was back in the game, but she wants to get back in there. They obviously called the ambulance to come and see this patient. What I'd like Linda to talk about is, what would you think when you're arriving there to assess these patients? What treatment are you going to give, and then what are you going to do?
All right. So just to give you a little orientation, around Region 3, which is our area that we serve, you can have a combination of paid paramedic level or flight nurses that can do very advanced procedures, or you can have volunteer EMTs, basic level personnel that service through the fire protection districts out in the county that come to your home or come to your accident and take care of you. So wide range of knowledge base behind them, but they all have one thing in mind, and that is to take excellent care of that patient and get them to the right place. So what are they thinking when they come up to a soccer game? Let's say, 5,000, 10,000 people there cheering on their state team and trying to get this female taken care of. We always start out with, is the scene safe? And you can kind of chuckle at that one because you can, believe me, some scenes at soccer games are not always safe. They want you not only to get that patient off the field, but they want you to do it quickly, and we want to do what's right for the patient. So the first thing they do is make sure it's good to go to get to the patient, and then equipment goes with you, and as you are approaching the patient, that's when the assessment actually starts. Is that patient awake and moving now, even in the short period of time it took them to get to the scene, because most athletic events have athletic trainers, et cetera, at the scene now. As we approach the patient, are they awake? Are they looking at us? Is their airway open? Are they breathing on their own? What are we going to do to take care of those very important things right away? Are they able to move air? Can they breathe on their own? Do they have a pulse? Are they moving things? Is there any bleeding? That kind of thing. So what can we do to take care of that? At the scene, we need to not just turn the patient haphazardly, but we will need to take control of that patient's head and cervical spine, and as a team, log roll that patient back over so that they're facing up on the ground. But that's done very carefully so that there is no complication with the spinal cord as we do that. They will need to manage that patient's airway if they're unresponsive, because they can't do it for themselves. May take putting special tubes in their airway if that takes place, putting oxygen on the patient, and then putting them on spine boards, cervical collars, head rolls, tape, straps, so that when we move them, they don't move at all. And so it takes time, and the whole time that's going on, oftentimes people in the stands are like, what's taking them so long? Well, what's taking them so long is doing the right thing for the patient and not getting in a hurry and making sure that they are safe in their packaging before we move the patient. As they go to the ambulance, then further treatment can continue en route to the trauma center, taking very careful flight or by ambulance and making sure that we're missing the potholes and what else we can do. A full assessment is done en route. IVs are started en route. Any other medication that's needed. None of that is done so much on the scene anymore, but in the back of the ambulance en route to the hospital or in the helicopter to make it safe for that patient. So one of the things, my goals tonight is to point out to you that you do not have to have a loss of consciousness in order to have a concussion. So many people say, oh, well, he wasn't knocked out, he's okay. Well, you're going to hear through all the speakers tonight that that's not the case. You can certainly rattle your brain and not lose consciousness. And we're going to give you some signs and symptoms that will help you as the parent, as the bystander, as the coach to figure that out. So I just want to point out a few things to you. In high school sports, the most traumatic brain injuries are from football and from girls' soccer. We actually found out that more head injuries, more brain injuries happened after the 1904 era when they started wearing helmets, because now people felt like they could use their head as a battering ram, right? So just having a helmet doesn't always help. It is important to wear good, appropriately fitting gear. Not all schools have that, not all players have that, but it's our responsibility to make sure that they're adequately protected and that they're taught how to hit without using their head. Additionally, I want to point out to you that following a concussion, and you'll hear this from many speakers tonight, that players should not return to play until they have been cleared by a healthcare professional and we're sure that they have no major residual effects from that. So how do we know in the field? What are you looking for as a coach, as a parent? What kind of symptoms will the athlete say to you? And as you go down this list, there's also a card in the back of the room you can pick up on your way out, a little wallet card for you to take with you that says these same things. As a coach or parent, what I really want you to know is these are very subtle signs. The player is not going to hold a sign up that says, I just had a concussion. They're looking at you or asking you to pick up on these subtle things, such as, do they appear dazed? Do they look like they had their bell rung? Are they stunned? Do they forget which end of the field they were playing to? All right? Are they confused about what their assignment was? Are they moving clumsily, dragging their feet, not balanced? Do they answer the questions that you ask them about the game, how they're feeling, who they are? Do they answer those quickly and ready to go, or are they stumbling trying to figure it out? And can they recall what was going on right before that happened or right after? The athletes maybe not reporting that right away. Many of them want to get back to play right away, and they won't admit it. And then later on they go home, and all of a sudden you say, what's the matter? You're not acting right. They may complain of head pressure or headache. They may have some nausea or vomiting, balance problems, double or fuzzy vision. Sensitivity to light is a big one. We see that a lot. Certainly noise. And then they just seem foggy. They don't have the memory capacity that they used to. They aren't doing as well in school, etc. And we'll address more of those as we go through the evening.
Another one is they keep asking what happened, what happened. It's kind of a repetitive questioning. A second scenario that we might see head injuries, very, very common, are falls. An example of this is a man who's found at the bottom of his stairwell. Was last seen yesterday, and his roommate was out of town and comes back and finds him laying at the bottom of the stairs with blood around him. He's really just grunting and groaning. His eyes roll back. He doesn't answer questions. He doesn't appear to know what's going on or move appropriately. Yep.
So, not all accidents happen where you can get to the patients easily. As you can see, this gentleman's laying at the bottom of a stair in a private residence. So again, that scene safety comes into play. So that's the first thing EMS is thinking. Can I get to this patient without a German Shepherd coming at me? Is there anybody in the house that intentionally shoved him down a flight of stairs? Are there signs that there was a scuffle beforehand? Or does this look like he tripped and fell? Or was he unconscious before he even fell? Those are some of the clues that we're trying to figure out at the scene. And at the same time, what medications is the patient on that I can pick up and take to the hospital with me to show us if the patient's on any blood thinners, anything like that. So in addition to that, as you looked back at that picture, try to figure out how you're going to safely get this person with spinal motion restriction on a spine board, get a C-collar on them, manage their neck and head, and assess them at the same time. Because we have to do all those things together. Is that airway okay? Are they breathing? You know, do they have feeling in their extremities? Any blood going on at the same time? So that's what we're looking for. This would definitely be a fun one to try to get them what we call spinal motion restricted, and then get them back up the stairs safely. It certainly can't be done with just 2 people, so we have to think about calling in extra help. And then, of course, getting them to the trauma center where we can get their full workup completed. That is the main thing. It's not just a head injury. We have to assess them head to toe. Okay. Oh, a couple more things for you here. At age 65 plus, we find out that 1 out of 3 adults fall yearly. Many of these falls can lead to, if not immediate death, especially if they're on a lot of anticoagulants, Plavix, aspirin, etc., but they can lead to deaths further down the line. In 2010, we see some numbers from the Center for Disease Control that showed us that emergency departments treated 2.3 million non-fatal falls, and over 500,000 of these were hospitalized. How many more never came to the hospital is my question. Never called for help. They just picked themselves up and tried to go on. And this ended up costing us about $30 billion. So here's scenario number 3.
This one is pretty common, as you know, so we've kind of been increasing the force that's gone on. This would be a patient who's driving his motor vehicle home. Nobody knows if they're, could have been intoxicated. He could have just been tired from working 2 shifts. But the car is found upside down. He's unresponsive. He's snoring. He seems to have difficulty breathing. He's breathing really fast, and he has a very weak pulse.
So once again, as we approach the scene, and we never park right up close because you don't know if this could catch on fire and have a major explosion issues, etc. Make sure the scene is safe, and certainly any vehicle that's off its 4 tires is not stable, right? So we have to actually stabilize that vehicle before we can even get in there and take care of that patient. You don't want your team hurt either, right? So as you can see from here, the yellow supporting systems on either side are little support systems that help keep that car from rolling over. So again, this is not something that can be done by a 2-person ambulance crew. This now requires the fire department to come with their hoses to set up for fire suppression. It requires rescue equipment and training in order to just make that car safe in order to get in and get to the patient. You're already seeing where the roof of that car is cut off. That can take a long time. We'll typically pop a window with a tool and someone will climb in there as soon as that vehicle is stabilized so it won't tip. But then the time comes where you're inside taking care of that patient, assessing them, managing their cervical spine and their airway, while your crew is actually cutting a hole for you to remove that patient from the car. We cut the cars away from the patient. We don't drag the patients out of the car. So everything has to take time in order to do that, and it's quite loud and scary for the patients at the same time. So that's a lot more, and you can see here the forces involved. Your body's tissues can only take so much stress, and we'll talk later about what can happen to the different body parts as that goes on. But as you can see, huge teams, lots of equipment. That's what's available for you because of your tax base to make sure that we are all ready in case you're involved in a traumatic event. So where are they going? Hopefully to a trauma center with this patient, because that patient has had a huge hit to them. Not only enough to tear their organs inside and bruise their organs inside, but also destroy a car like that. Most cars anymore are built not to tip up on their side.
So we like to talk about a couple of things with these. And then I can go back and forth. In the trauma world, we don't like to use motor vehicle accidents as a terminology we call crashes. The reason we use that is to get people to be thinking that there's things that can be done that can avoid these injuries. Various types of preventions, various types of protection, whether you have belts on and airbags in the car, whether you're wearing the belts properly, on motorcycles, bicycles, wearing helmets, wearing protective clothing for people who are on motorcycles. Because the mechanism of this is what determines all the forces that are applied to the body. Head-on collisions are going to have a different type of impact, particularly if the dashboard gets pushed back into the patient or the engine block gets pushed back. Rear collision is different, a T-bone, a rollover. If you're unfortunate enough and weren't wearing a belt, you get thrown out of the vehicle or partially thrown out of the vehicle, which obviously increases the risk of injury if you're hanging out of the vehicle and it rolls over. So all these things kind of go into our thought processes when we see a patient arrive, deciding what are the degrees of injuries, what needs to be done for the patient.
Okay, so this slide is showing you that for every hit that the car takes, there are actually 3 hits. So you're strapped in a vehicle, even with your seatbelt on, this still happens. Your car hits the object, let's say it hits a concrete abutment. That's 1 hit. Then your body is going to slide forward and hit the inside of the car. That's a 2nd hit. And the 3rd hit that happens is the organs slide forward and hit the inside of the body. Now that's with just 1 hit, 1 crash. If you spin out and another vehicle hits you, starts all over again. Okay, so lots of forces happening to this body. And as you look at this, you can see energy has to go somewhere. So as your feet crush into the floor pan, it travels up and into the femur area, into the thigh area, into the lower back, and your head is whipping forward and whipping back. And that causes your brain to slide on the inside of your skull, and damage gets caused in the front, and damage can get caused in the back when that happens. So even with restraints on, this is the damage that can happen. All right?
So we were talking about the patients and where do they go and what should be taken care of. We have kind of these 5 R's that go on. We want the right patient. So you don't want patients who are just mildly injured, but patients who are severely injured or meet certain criteria. You want to take the right amount of time to get that patient. So you don't want to spend a whole lot of time waiting at a scene, taking care of the patient, or a lot of time for somebody to be notified about them or to get the right crews. You want to have the right amount of time, go to the right hospital with the right physicians. And we'll talk about what a trauma center is and how that works. And at the end, if you really want the optimal results, you've got to have the right rehabilitation. You have to have the right people that are able to take care of that in the right center. So what is a trauma center? These are some photos here of kind of what it would look like as you come in here at Memorial to one of our trauma bays. There is very good data to show that if you are in a severe injury that meets the appropriate criteria, not only do we do a better job, fewer people die. I think that's like the best outcome. You can keep people alive. So 25% less chance of dying if you are taken to a designated trauma center, and particularly to a level 1 trauma center, compared to going to just the local hospital. Why does this work? It's a huge outlay of resources for the institution, a huge outlay of time commitments for the physicians and the nurses and the staff. It's really a combination of having all the personnel, the people who have the experience, have the resources. The hospitals make sure that we have a CAT scanner that we can get somebody in there at any time. It's just available. We get priority. We have the right protocols. People know what to do. You don't have to tell everybody which step. They know exactly what to go through. And able to take care of these severe injuries. Operating rooms available 24/7. Able to get blood at a moment's notice. All these things are what go into making a trauma center work. Why is a trauma center important? It is the #1 cause of death for people under the age of 40, far and away. I mean, there's nothing else that's even close. It remains up to, or at number 3 is the lowest one for all age groups. It costs this country a lot of money to take care of it, more than $100 billion annually. And these are old numbers. I think these are from like 2004, the last time I had a good number. And the sad thing is, this is often preventable. So if we want to help balance our budget, if we prevented spending a lot of money on injuries and get people back to work instead of having them have to get taken care of, we could do a lot of good. Now there's also, many famous folks that have died in traumatic things. Princess Diana in this car crash in France. Natasha Richardson, who was at the time the wife of Liam Nielsen, is that right? Yeah. Who actually fell down on a ski slope in Canada and hit her head and eventually succumbed to a head injury. The reason I put these two up, these are two cases that have been looked at quite extensively in the U.S. trauma literature. Fairly good consensus that had Princess Diana crashed in New Jersey instead of France, if she would have had this happen in L.A. or Seattle, you got a pretty good chance she would still be alive. The trauma system very different in France, with hours taken to get the patient from the scene to the hospital. And I remember I was on call the night that Princess Diana was injured. I saw it on the news. I got paged for a trauma, took care of a trauma, came back. It was still on the news. They were still getting her out of the vehicle. Got paged for another trauma, took care of that, came back, and they were still working on her. So I firmly convinced a system would have saved that life. And also in this other case, Natasha Richardson's case, more rapid attention to those subtle findings of head injury, the nausea and the vomiting and the stupor, availability of air evacuation. She had to be transported by ground, whereas we have air transport. Again, potential chance to save these two people, and obviously this happens thousands of times across the world. So what is our trauma center? We cover Illinois Region 3, which is right here. Is this laser pointer also working for you, or is it just me that sees it?
It doesn't show up very well.
Yeah, I know it doesn't show up very well. That's why I wanted to, maybe if I go like that, I don't know. We have 3 sponsoring partners, which are both the hospitals here in town as well as the medical school. We started in July of 1999. And the goal in the trauma center is to reach patients in what's called the golden hour. It's actually longer than 60 minutes, but generally the idea of getting to patients before their disease becomes irreversible. So, you kind of wonder, what in the world are we thinking when we're rushing these people around? Well, when we're rushing these people around, we have our priorities. And as opposed to this gentleman who has different priorities, we, I think, have our priorities straight. We have the ABCs. So when somebody comes in with a potential head injury, if somebody comes in with a minor one, or if somebody comes in with a major car crash, we're doing the same thing. Making sure there's an airway. We want air to get into the lungs. Breathing, we call, is the B. We make sure that the air that gets into lungs can actually be utilized. So we want to make sure there's no collapsed lungs. Circulation, we want to make sure that that air that gets into the lungs and is used can actually then circulate and get oxygen to the rest of the body. So all these things, ABCs, are what we do immediately. Then the D and E on that is disability. We look then for what is a specific neurologic injury. And exposure, we like to make sure that we look all over the patient for subtle findings. Then we do our assessments. A head injury, I mean, everybody's going to tell you that the first thing we're going to do is get a CAT scan of the head. That's what to do for. But we're looking for these other injuries also. High rate of spine injuries when you have a head injury. That's why everybody gets immobilized. Chest injury, abdominal injury from the force of a motor vehicle crash or a fall, or even a soccer collision or a football collision. We've had people rupture their spleens from that type of sporting injury. Obviously, we look for fractures and any kind of cuts and bruises and things of that nature. So talk a little bit about what we do with our sports concussions.
All right, so it's out there now pretty well, but we want to make sure that everybody hears it, and that is that any athlete who has a suspected concussion needs to be removed from play, evaluated by a healthcare professional, make sure that they don't have problems, and should not go back into play until they have been cleared by a healthcare professional and are free of any symptoms when they get back to exercise. And I'm sure they're going to go into more of that here tonight. But we want to point out to you that you as a parent, you as a grandparent, or a friend even, should help that person realize that, yes, the scouts are here, but this is not the time for you to be playing. So what do? We do a lot of education and community events type like this, and we try to talk to coaches and players and parents and let them know about secondary brain injury that can happen if they go back in too soon. You're welcome to look up more information. Our government, the CDC, Center for Disease Control, has a wonderful collection of data and handouts and things on concussion at that website, cdc.gov. We like to encourage pre-season baseline testing, and they'll talk to you some more about that in a little bit. We like to make sure that helmets fit. Not every school district is wealthy, and oftentimes helmets might be passed on from one to the next. Bike helmets, certainly, if they're cracked, should never be used again. All right, so you can't. We don't let them take them home with them if they've been damaged. We encourage people to teach proper hitting techniques, not spearing with the head and using a head-down tackle, but using your hands instead. And always encouraging people to understand that it's better to miss a game, it's better to miss several games than to end up with a life-altering injury. So, what are some of the things that you can do to prevent fall-type injuries? As we age, our muscle strength typically lowers, and you can exercise regularly to try to improve your strength and balance. Review medications with your doctors. Do I still need to be on this medication? It makes me sleepy, and I don't walk well, especially if I have to get up in the middle of the night. Have your vision checked each year and make sure that the prescription you have is good. And, you know, we're all trying to cut back by putting in special light bulbs that aren't real bright to try to keep our electric bills down. But that's not always the safest, especially for the elderly. You know, make sure that the lights are bright in the room, that they don't have throw rugs around, that they're pets, and I have one of my own that I've tripped over several times, right? That we're not tripping over our pets in the throw rugs, have handrails, and that they use them as they go up and down the stairs. And the one that's my favorite is reduce that clutter in the walkway as you walk through the house. You know, just look at it and say, if I haven't touched it in the past year, let's get rid of it, okay? And then just making sure that your pets try to stay out of your way. So this is just a little cartoon here. It says, if I tell anyone I've fallen, I'll lose my independence. And really, that is how many elderly people think. You know, if I go to the hospital, I'm never coming out again. Or if I tell my family, they won't let me live alone anymore. And that's not a good thing. We want them to understand that they can go see the doctors and let them know that they've been falling more than usual, and we can check their vision and their medications and give them some advice on how to improve the home so that it's safer for them to be there, and help them get signed up for some exercise classes. They're not all on your feet. There are exercise classes that you can do sitting in a chair. So this is, you know, our soapbox all the time. Motor vehicle collision prevention. How do we do that? Don't answer your cell phone if it's ringing in the car. I actually said to a teenager one time, well, put it in the back seat if you're so tempted to grab it. And she said, but then I get in the accident when I reached for it. So really bringing them back down to, you don't need to answer it, you know, you just don't. So no texting and driving. It's now against the law in the state of Illinois. Keep your eyes and mind on the road. You know, we have a tendency to eat full meal deals while we're driving. Not always a great thing. It's a law in Illinois that every seat in the car has to have a seatbelt on now, not just in the front seat. So please encourage that one. Again, wear a helmet that fits and is of the right quality for the procedure that you're doing with it. And then I'm a firm believer in Illinois' restricted driving. As you begin to drive, you can only have one other person in the car with you, of a family member, one other person in addition to that. And I think that saved a lot of teenage lives in Illinois because they are not getting as distracted. And then next to motor vehicle collisions and falls, I cannot tell you how many ATV accidents we see here in Central Illinois. We're a farming rural community, and we see people putting 2-year-olds on ATVs. So please, if you're going to do that, do it safely. Take some lessons beforehand, and don't just go to a friend's farm for the day and decide you're going to take a ride. So, as you continue on with the rest of your speakers, we ask you to please be careful out there. All these different things that can get you.
Well, thanks for listening. And I forgot to mention under Linda's major qualifications is she's a mom and did survive 4 years of football in Chatham. So she knows what she's talking about. So I think our neurosurgeon is up next. And is it really this easy? Yeah, okay.
And then getting your plane tickets, right? You guys hear me okay? Yeah, it was an excellent overview. Touched on some of the more serious aspects. I'm kind of going to dive into that area. What happens after we're in the trauma bay? I think the entire network does such a good job of doing exactly that, getting patients here within the hour. And then once they're here, what are things we can do to intervene to make it a survivable, rehabable insult to the nervous system? So just to touch on incidents, I kind of have this pyramid, and that's kind of the way I want to think about it. We've moved around through the different aspects. There's patients who maybe go to the emergency room. This could be a pretty serious hit on the football field. This could be falling off your bicycle. It could be a car accident where people are not certain whether there is or is not an injury, so they get evaluated. You can see that's 1.3 million visits a year. Obviously, 1 million of those go home from the ER. So that gives you kind of the first tier aspect. Obviously, at the base of this pyramid, we're talking about evaluation by athletic trainers, things that don't require a formal visit to a physician. We don't really have any numbers on this, so you can just sort of imagine that obviously this pyramid gets broader. You're talking about something that happens to basically all of us at some point in our life. So we're really talking about something that's general. As you get to hospitalizations, this is someone who at least spends the night for observation with a lot of things in the nervous system. If you're getting better over the next 6, 12, 24 hours, that's very reassuring. Sometimes we just can't be certain that people are going to be okay if we send them home, and kind of testing that hypothesis isn't something we're willing to do. So if there's any concern, lots of people spend a night in the hospital. At sunrise, we're much less concerned because they're much more back to their baseline. They've still presenting with some symptoms, but they've improved quite a bit. And then we have this 52,000 deaths a year. So coming back to the overall base of the pyramid, 1.7 million people in a population of 300 million really adds up to a sizable problem. And I think the emphasis that maybe John deserves more credit for is the fact that this disease process, if we talk about traumatic brain injury as a disease process and trauma in general, this is really striking people at a time in their life when there's so much to be gained. There's so many years ahead. There's so many years of productivity. So the cost to the individual, to society, however you want to phrase it, what we want from our health care system, when we all sort of sit back and think of it, healthy as we are, really good trauma care, I think, would all put at the top of the list. Probably only behind possibly really excellent children's care when we sit back and think, well, what should this healthcare system be doing for us? And I'd like to classify, and then we'll go through an actual anatomic picture, a CT scan of what these are, so we can kind of dive in, and you can leave here with kind of an overview of something you would not otherwise get a chance to sort of get exposed to, what this looks like on a CT scan. Concussions are sort of by definition not going to have a finding on the CT scan. They're going to show a normal brain, normal skull, no extra blood collections if the only thing that we're talking about is a concussion. That doesn't necessarily mean there's not an injury, there's not a disruption to the network, there's not an effect on the patient that can be days, weeks, months, perhaps lifetime. Epidural hematoma, this is a blood clot hematoma, just meaning we've accumulated some blood, there's been an injury significant enough to tear some blood vessels, like maybe a large bruise to the thigh, where there's blood that's collecting in the tissues. Same process, but now it's in a confined space. The skull encloses the brain as a rigid built-in helmet, if you will, but there's no extra give if there's any accumulation of material. This is on the outside of a thin, leathery lining called the dura overlying the brain. So the blood doesn't technically contact the brain, and this is often associated with some form of skull fracture. It can be some of the thinner bones of the skull, facial bones, that allows blood to collect in a space on the outside of this leathery lining. A subdural hematoma, this is just one layer in. Now, against the brain, and inside of this leathery lining that's on the inside of the skull, there's been a collection of blood. And this can cause problems by its very mass. It can be the size of a chicken breast or larger that suddenly is taking up space inside the skull with the brain and causes dysfunction just from what it's pushing on, not just from the actual injury, but now you have a second problem that's going on. Not only has the brain had a shockwave injury to it, now it also has something that's deforming and causing dysfunction. A contusion really is the purest form of a bruise to the brain now. You mentioned that the internal organs strike against the body wall. Well, when the brain strikes against the inside of the skull, sometimes small tearing and bruising of small veins, arteries, causes a collection of blood within the actual tissue of the brain. Because of that, there can be dysfunction, there can be seizures, there can be ramifications, and this is something we can see on the CT scan. Diffuse axonal injury, this one I want to kind of highlight because, if you will, this is the description of what traumatic brain injury really is. What is it to have a mechanical force to the head that results in brain dysfunction for a period of time, up to years perhaps. Diffuse axonal injury, I usually explain as, just imagine an earthquake shakes the town and some of the telephone cables are torn. You can't get to Bobby's house anymore by calling directly. You have to call the neighbor and ask them to walk across the street and grab somebody from the house. You need to tell them something. That's kind of what the brain has to do as it heals from this process, is it has to remap the network. It has to learn what it no longer has access to and what alternate pathways are there. And this can happen to people's strength, speech, reaction times, cognitive functioning. This gets to actually the essence of the person. This can be their personality. This can be their function at work. So we're really talking about an injury here is an injury to the person, not the person's spleen, but the person itself. There's cerebral edema, which is not necessarily a focal dysfunction, but due to the injury, the overall brain tissue begins to swell. Lots of tissues in the body swell when exposed to injury. When the brain swells, the problem is it starts to squeeze other parts of the brain and cause dysfunction at different spots, which are just mechanically disadvantaged. They are up against a hard surface, they're up against a sharp curve, and therefore when everything swells, we see dysfunction at these places, and this is something that we can intervene with medically, possibly even surgically. And then skull fracture, just listing this here as well. Obviously, if we're talking about trauma to the head injury, there can be fractures to the skull, and they can be accompanied by these other injuries, but in and of themselves, they tell us something about how much force was applied. In this case, where the skull is fractured, the skull is actually doing its job to dissipate the injury, the same way a fractured bike helmet did its job. This is a fracture of the skull itself. The whole goal or hope is that the injury doesn't get propagated to the brain, which is certainly something that doesn't necessarily heal as well as the skull. So to take a look through these, a concussion, as I said, should be essentially a normal scan. And this is a mid-slice of a CT scan. The bone is white and the brain is this gray area. And we can see a little difference between this gray and this gray. I'm not sure how well that projects, but that gives us the difference between the gray matter and the white matter of the brain. Two different water densities is what the scan gives us. It shows us some of these water spaces that are inside the brain, called ventricles. Like in the heart, they're spaces that contain the cerebrospinal fluid, which circulates 3 times a day. It's made completely new. It provides nutrients, cushioning, cooling. It provides a lot of sort of functions for the brain. But what it tells us on the scan is if there's edema, if the brain is swelling, these spaces get smaller. The water inside the skull is pushed out because it can go into the spinal canal, and it can then displace veins and other structures that can give up space, and that can be a sign that we can see in the CT scan. But if someone has had a concussion, and this could be something where someone was unconscious for seconds, they maybe are not unconscious at all, they just had a sharp hit on a football field or fell off of their bike, or this could be someone who was knocked unconscious for 15 minutes, came to over a period of an hour, the CT scan could look the same, just meaning that anatomically, at least with a CT scan, we don't always see the injury. The injury is something we have to detect more clinically. Now coming to an epidural type of a hematoma, this abnormal gray color here, this is blood that is collected, and it's pushing on the brain. It is pushing the left side over to the right side. You can see it's also present over on this side. And this one was associated with a very dramatic fracture over the top of the skull, and blood had started to accumulate, but was still outside of the lining of the skull. A subdural hematoma, this blood now is literally lying against the brain, and so it takes the shape, the contour over the surface of the brain, and it causes its problems. This one isn't particularly thick, and we have to make, as neurosurgeons, a judgment. Is this too big? Does this need to go to the operating room and be evacuated in order for the best possible recovery to occur? And this type of a scan might be something that we bring our hands a little bit about. Different people might make a different decision, but it's the overall picture we have to consider. But this is a picture, if you will, of injury to the brain, that there has been a blood vessel, typically a vein, that's been torn, and the bleeding has continued until there's a back pressure, if you will, that forces the blood to no longer continue to come out of the vein because the pressure now within this subdural space is as high as the pressure in the veins. We also worry that this can get worse overnight, after they're admitted, after the CT scan. These are all the kind of things that concern us in the trauma pathway. A contusion is a bruise, and the surface of the skull in this region is a little bit rough. It's not a perfectly smooth surface. And so as the brain slides forward and backward very rapidly, it actually gets scraped, if you will, against the bony surface. And this coloration difference here is essentially a bruise. The same way it looks on your leg, on the inside of the brain, it takes months to completely go away. If we scan this patient 2 weeks, a month from now, we can still see some of the effects. And this concerns us because, like a bruise, it may swell, and now we get into the same type of pressure problem within the brain, that it can be squeezing on the brain, causing unaffected parts of the brain to now be affected by the fact that it's contained within the skull, with this portion of the brain which is injured and expanding. And this is a picture, diffuse axonal injury. When these telephone cables, the axons of the brain, are sheared and torn by the force of the brain moving within the skull, some of the small blood vessels, basically capillaries, get torn as well. And when they get torn, they produce little dots of blood. Nothing dramatic like the previous pictures I've been showing you, but when we see this, we know a lot of force has been imparted onto the brain. We are sort of looking at the picture of traumatic brain injury. This particular scan could go along with a story of a motor vehicle crash and a young person who may not interact with us, follow commands we say, but may not be able to talk or understand what we're telling them for a week in the ICU. And it's this type of an injury. This diffuse axonal injury is just what it says. A lot of the network has been damaged. No one particular part. It's not that they will never talk again, never walk again. It's not that it's the right or the left side of the body. It's that the whole brain, personality, speech, thinking, reaction time, the whole brain has been affected. And then cerebral edema. I didn't have a picture that showed what would happen in the late stages, but here we start to see a portion of the brain, the uncus, which is famous for swelling caused in the temporal lobe, will start to move the portion of the temporal lobe that hangs over, if you will, and it starts to push on the midbrain. So this being the brainstem, any kind of pressure to the brainstem starts to interfere with the basic functions of life. Breathing, consciousness, pupils. This is where we get our dilated pupils with head injury, one of the clinical signs easily recognizable from all the way out in the field just after you've made your initial assessment, and carries a lot of meaning forward. In a patient with one pupil that's dilated, motor exam seems to be different on one side or the other, we already have an indication to start medical treatment to that patient all the way at a point before the CT scanner. And I don't want to show these CT scans to give the impression that we sit by sipping our coffee until we have a CT scan. Sometimes these patients need to be resuscitated. They have spleen and liver lacerations. They are not heading straight for the CT scanner. There are still things that we can do. Clinical medicine still underpins this whole process. And in this case, with a dilated pupil, we're getting a sign that we need to reduce the pressure in the brain. A closed skull fracture, something where the thinner part of the brain, the skull here, has been fractured. And this is a part where essentially underneath your jaw muscles. And a more significant injury can produce an open skull fracture. This can be the dramatic stories of gray matter seen on the scalp. That this is an injury where the skull, the dura, and the brain is actually lacerated. It is actually an injury that deep. So where we start, I guess I'm sort of number 4. I'm the 4th R in your 5 Rs, and I'm also the D in ABCD. I think that was a movie, wasn't it? I am number 4. So we are the deficits, and I just recently heard that people are debating the juggling of the B and the C. Nonetheless, the principles are the same. The brain needs oxygen every minute of every day. You can hold your breath for about 2 minutes. That doesn't mean your brain can. Your lungs are filled with a breath of air. It really comes down to there's nothing we want to do neurologically for the patient until you can make sure the heart is pumping a quantity of oxygenated blood, which comes down to airway, breathing, circulation, and deficits. So when I'm rounding with interns and things like that, you still have to refocus that although the scene can be very dramatic, the first thing a neurosurgeon wants to do for the patient is ABCD. Once that's established, then we can move on to pupillary size. So signs of herniation, asymmetric pupil size, posturing signs. There's specific things that the patient can be doing that can be spontaneous, in fact, and can be part of an initial observation. Signs of the tone, essentially the communication from the brain and the upper parts of the brainstem is no longer connected to the lower parts of the brainstem, in which case minor stimulus, and these trauma patients are being stimulated by numerous things such as intubation, lots of things that are happening are uncomfortable, and they can spontaneously be showing you signs that there's a severe inside injury, and we can start to treat that, like I say, even before the CT scan. We can start to give mannitol if we're seeing signs of posturing. Deterioration is something where we have to recognize what's happened as the trauma situation, but where we can really make a difference is by intervening on what happens once they're here in the hospital. So if a patient shows up and they're somewhat confused but otherwise well, we have to recognize that when 2 hours later they're not even that well, they're deteriorating. And so 2 points on the GCS scale, which I'll talk about in a minute, is an important thing to recognize. That's one of the things that's important. You monitor their blood pressure, you monitor their heart rate, you also monitor their neurologic status. And that's one of the things you do in the trauma bay from the minute they arrive. You have to have a sense of what were they like on presentation. Also, a report from the field can be useful, but you have to know when a patient's going the wrong direction. So in the trauma bay, we examine the patient. The Glasgow Coma score gets its own slide in a minute. Quick things you can see on their face. Raccoon eyes. This is indicating skull fracture. There's some blood that's spilling out into the orbital space. Battle sign. This is another skull fracture sign. It's blood showing up around the ear area behind the ear. There can be clear fluid leaking from the nose or ear. If you look into the ear spaces, you can see that there's blood behind the ear. Lefort fractures, these are a type of facial fractures. You can just feel the patient's face to see what kind of energy has been imparted to the face. Orbital rim fractures, again, just palpating around the eye. These are all starting to get your level of concern up. Proptosis, if the eye is physically protruding, or seizure, either reported seizure or witnessed in the trauma bay. These are all signs that the injury is more significant. So the other things we can find, cranial nerves 2, 3, 6, and 7. So that's their vision, the way their ocular muscles are moving around, their pupillary reaction, and facial symmetry. There's a part of the facial nerve that moves the face, that runs through the skull, that can be injured from a skull fracture. Level of consciousness, their motor exam, if they're not moving their extremities, a rectal exam to find out if we're dealing with some sort of a spinal cord injury, a set of sensory examinations if the patient's awake and talking to you to see is there some level beyond which their sensation is different, and their reflexes. These are all things that can be done as part of the initial trauma evaluation. The Glasgow Coma Score I want to spend just a second on because I've found it a very useful way to bring interns, medical students, and to get their head around the neurologic side of evaluating these patients. It has to do with 3 categories of assessing the patient. It's eye opening. They can either not have their eyes open no matter what you do to them. If it takes a painful stimulus to open their eyes, they get 2 points. If they'll open their eyes to a loud voice, they get the 3 points. And 4, they come in with their eyes open. Obviously, that sounds like that's categorizing patients. If you do nothing else than that would help you categorize how injured this patient is from a traumatic brain injury. Verbal, again, working your way up. They could not be making any sounds. They could be incomprehensible. They could be saying words that aren't appropriate. They could be saying words, but they're confused. They're not quite the right situational, and then they could be oriented. And they could be intubated, in which case this whole category becomes a T, and they always get 1 point. The lowest score is not 0 in this. The motor exam I find to be the most important for categorizing these patients. And if you step back for a second and ask what this means anatomically, you get a pretty good assessment of where that patient is. You give the patient their best examination, and if the patient is not moving, you have to ask questions of whether paralytic medications are on board, but obviously that's concerning when a patient's been injured and has not moved, went limp. That's a real concerning state. Extensor posturing and flexor posturing, these have to do with higher input from the brain being removed from the spinal cord and brainstem. So these are, in a sense, sort of right next to each other anatomically. They're both very bad. There is not a large difference between these two. Withdrawing to painful stimulus, if all the patient will do is sort of pull their hand away, well, that's certainly better than the lower states. But it's not nearly as good as if they will localize. If something's annoying, if you're rubbing their chest real hard, and they can reach up with their hand, you have to ask yourself what happened inside the brain. Something's hurting. Where is it? They answered those 2 questions correctly. How do I get to it? And they had a motor plan, and then they executed that motor plan with their hand. Actually, everything's functioning from a neurosurgeon except for speech. You've just tested the whole higher circuit loop, and if they're localizing, that's reassuring in a trauma bay. And if they follow commands, this is sort of our holy grail. This is really where we can start to relax. When we ask them to wiggle their thumbs and they do, that means I heard something, I processed it correctly, I understood it involved a motor plan, I used the motor cortex of that side of the brain, I executed the task. That gives us a lot of reassurance. And so things that interfere with that level of exam make us increasingly anxious. So then to categorize the different kinds of patients that present, GCS 14 or 15, this patient is basically at most confused typically. So somebody's had their bell rung, they don't know who the opponent is, they're already down at a GCS 15. And for these patients, this is where we might be admitting them and just watching them overnight kind of a situation. We may not feed them until they improve back to a true GCS 15, worried that they may deteriorate down while we're observing them. Moderate injury, this again can still be a patient that's seen in the ER. They're not intubated to have scores like 9 to 13. This is someone when we're worried that the scan now may look fine, but something may happen overnight. So we may scan this patient with a CT scan in the morning to make sure a bruise happened but wasn't seen on the CT until the next morning. Because we really got to find a reason for why their glaucoma score is 9, 10, 11, and we're really not going to relax until they at least get up to a GCS 14, at most confused sort of a situation. In the severe GCS categories, these are the patients where we're really concerned that one of the scans that I just showed you is the underlying reason for their poor exam. This is someone that we're worried may not even breathe properly. So they're typically intubated when we get GCS less than 8. Sort of by definition, this patient's not responding appropriately, following commands and opening their eyes. Something else, a lot of things are happening right now. Global dysfunction of the brain. We worry about sodium to control cerebral edema. We look for another scan of the head to make sure that things aren't worsening. If we've observed them and we don't have a medication, hypertension, some other reason for why their GCS is this low, we're going to proceed with placing an intracranial pressure monitor. We're going to hypothesize that the reason their exam is so poor, now that everything else has been ruled out, their exam's poor because their intracranial pressure is high, and that's the one thing we can do something about to improve their outcome. So in that case, we can either place a rubber tube, which can drain cerebrospinal fluid, water essentially, off of the brain, and help to relieve the pressure by physically reducing mass. Or we can place a monitor that is a smaller fiber optic, just a pressure sensor, can't remove any CSF, and then we can treat with medicines such as mannitol and hypertonic saline. If those measures don't work, we're out of our medical options to reduce the pressure, and the pressure is now elevated. Brain pressures are considered normal when they're below 20, and that's centimeters of water. We may perform a craniotomy to evacuate a mass lesion. There may be brain tissue that's so injured that it's swelling and injuring the normal or healthy functioning opposite side of the brain. Sometimes we have to remove that tissue in order to actually create space. We may remove a whole section of the skull and leave it off, either placing it in the fatty tissues of the abdomen or placing it in a freezer for replacement at a later date. So this is what an ICP monitor looks like here, where we've drilled a small hole in the skull and threaded a metal bolt, we call it, because it's exactly what it gives you the sense of, and then a small catheter comes through and measures the pressure once it's zeroed. We can also have a drain. This is a picture of the actual rubber tube. It's linguine size, has some holes at the end that will act like a French drain and pull off the water if it's placed within the ventricular space. And here's a picture of one in position, and it's in position so that it can withdraw fluid from this area, and then it can measure the pressure and tell us if our treatments are working, keeping the pressure at a normal level. If things get to a more significant, serious level, our medication regimen is failing to control the pressure. In this case, we can remove an entire section of the skull and allow, essentially, swelling to have some more space. We're actually creating some more space for the brain. That's what this may look like on another projection. In this case, the brain is not swollen out past the edges of the skull, but you could also have a situation where the swelling is pushing out for a day, 2 or 3, and then usually that starts to recede, hopefully. So this all results in, hopefully, a good outcome for the patient. These are the interventions we can do to try and help the body heal the injury that's happened at the site of insult. And the things that can still occur, despite the best of our efforts, is seizures. Basically, a short circuit of some circuits of the brain can be a long-term outcome for the patient, post-traumatic seizures. Communicating hydrocephalus, the way the brain reabsorbs its water, can become dysfunctional, and they can require placement of a shunt, extra rubber tube to drain this fluid long-term. Post-concussive syndrome, this syndrome of headache, nausea, dizziness, and lethargy, this can last days, weeks, months. This is what we're talking about when we say the patient has to be symptom-free before returning to play, symptom-free while exercising. The increased blood pressure seems to bring on symptoms. So that's what sort of tells us that the post-concussive syndrome is not a problem for this patient. And then we see these patients in the ER. If they're going home from the ER or if they're spending one night, we see them back in clinic in about 2 to 3 weeks, and we ask them, how much of this are they experiencing? We can't really predict just from the scan or what happened to them. It really is, how did it affect the patient? We have to ask them, what symptoms are they having? And then there's a topic that's gotten a lot more interest. I'm not going to dive into it, but chronic traumatic encephalopathy. We're sort of at a point where we're kind of proving the obvious, that prize fighting can be bad for the brain. We now have, actually here, we have Dr. Brian Moore, who's done a lot of research into this and has been on local TV and radio programs talking about what this is under a microscope, which is his expertise, and what it causes. And we've seen the effects in some of our athletes, Muhammad Ali, Troy Aikman. We've seen some of these things making a lot more headlines because we're realizing that there's a chronic phase of this, and we're trying to find ways to eliminate that. And one of the things we found is that a second injury within 2 months of a first injury can be worse than either of those 2 injuries if they were separated by, say, a year. And so that's some of the things that are propagating down into the recommendations all the way down to high school sports. And then the development of Alzheimer's disease. It's somehow linked that the way the body heals these chronic insults can actually lead, in certain individuals that are predisposed perhaps, to these plaques, these tangles, these dysfunctional formations in the brain that cause Alzheimer's disease. So I'd like to thank you all for your attention. I hope you enjoyed a trip kind of inside the head with me and looking at some of these, and leave that, and we'll take some questions at the end.
Everybody hear me? 2 excellent presentations to follow. I get the fun stuff. I get to talk about the rehab of the brain-injured patient. Now, I'm going to be focusing my talk really on kind of what we do with our inpatient traumatic brain-injured patients. I know there's been some discussions about post-concussive syndrome. I know there's some people in the audience that have dealt with this. I'm really not going to be addressing that in terms of treatment. What I would do, I'm happy to answer questions about that in the panel, but in the back of the room, back in the left, Devin Spears, who's one of the athletic trainers with Sports Care, I always get the 2 names mixed up, with Memorial Sports Care, has a poster and some pamphlets and handouts on post-concussive syndrome and some references to the clinics and the stuff they do with athletes. So if anybody has specific interest in that, can talk to Devin afterwards. So I'm going to talk about traumatic brain injury, what it does to the brain, what it does functionally in terms of impairing our patients. I'm going to talk a little bit about what rehabilitation does to help rewire the brain. I'm going to talk about the rehab team specifically, what our different rehab team members do, how they help brain injury patients. I'm going to talk a little bit about recovery and prognosis. There are some features that patients have with regard to brain injury that give us a little bit of an idea about how they might do in terms of their rehab outcome. And I'm going to talk a little bit at the end about just some community services that are available for our patients from a rehab perspective. We've seen some really nice scans of different injuries to the brain. As a neurologist who does rehabilitation, obviously I'm interested in the deficits that brain injury patients have. Certainly our therapists are, because we're trying to design a rehab program that helps them. And similar to disorders like MS, brain injury patients can be injured really anywhere in their brain, and the signs and symptoms that they have depends on where that brain injury is. So really, really not any 2 traumatic brain injury patients are the same. You've seen some slides of injuries to the brain. That's just a contusion that Dr. Amin alluded to before, more widespread injury in the frontal areas. That's what bad brains look like, and these are often the patients that we get, if they survive these insults, to our rehab unit to try to rehabilitate them. So, Dr. Amin alluded to different injuries that you can have to the brain, and one of them that he talked about were contusions or a bruise to the brain. And again, the signs and symptoms that we see depends on where that contusion is going to be. If it's in the frontal lobes in the brain or in the deep white matter pathways, patients might have weakness, typically on one side of their body, but if they have a big traumatic brain injury, they may have paralysis on both sides. Patients may have loss of sensation or feeling. If the injury is to the left hemisphere of the brain, patients may have problems with language. They can have cognitive problems, problems with thinking, memory, attention and concentration. Milder brain injuries commonly cause problems with things like multitasking, those cognitive issues. And if the injuries to the brain are to the back part of the brain, or the occipital lobes, or their pathways, patients can have problems with their vision. So again, the different deficits that we see on our rehab unit really depend on where that injury is. And as Dr. Sutyak talked about, it often depends on the type of injury they have. If they get hit, he talked about you get hit in the back in a car and you have a whiplash injury and your head goes forward, you may have a different type of injury to the brain than if you get hit on the side. Dr. Amin also alluded to the diffuse axonal injury or the shearing of nerves deep in the brain. This is typically injuries to nerves and their pathways that travel deeply in the brain. And patients that have this often have problems with spasticity. They often have weakness on both sides of their body because the deep structures are involved. They often have problems with their thinking, and very commonly problems with bowel and bladder function, especially bladder. And these are, again, issues that we have to deal with when we're rehabilitating patients. This is just a schematic. Dr. Amin talked about the diffuse axonal injury and the shearing of axons. Actually, his description of the telephone cables being torn, I think, is probably the best I've heard. And I'm probably going to steal that from you, Dr. Amin, in the future, because I really like that. And that's essentially these nerve cells are cables of wires that travel through the brain, and they are literally torn apart. And this very commonly causes permanent injury to our patients. Patients that have this typically don't do as well as just a patient that might have a simple contusion to the brain. And there's just the scan, again, of some of the little white spots in the brain that we see in patients that have diffuse axonal injury. Dr. Amin showed a slide like that before. Now, on rehab, what we're most concerned about is function. So it's great that patients are weak and they don't feel things very well and that they're confused, but what we're really looking at are functional consequences. So patients that have brain injuries may have problems with their mobility. Mobility being ability to get in and out of a wheelchair, get to the bed, get up and walk. They may have problems with their activities of daily living, bathing, dressing, feeding, grooming, toileting. They may have problems with their swallowing. We may have to adjust their the dietary consistency in the hospital and after. Again, many patients with traumatic brain injury have problems with language and cognition, and I've already mentioned bowel and bladder dysfunction. So these are the issues that, again, that we're going to be dealing with on all our patients when we're planning a rehabilitation program. Now, what exactly does rehabilitation do? 24 years ago, when I started practicing and started doing rehabilitation, if you had asked me, we would have said that rehabilitation definitely teaches compensatory techniques. So one of the things that we can do is somebody has a paralyzed arm, our occupational therapist, Emily there, can teach the person how to use the other arm to compensate for the loss of function in the left arm. So a lot of what we did many years ago really focused on teaching patients to compensate for deficits. And we really weren't quite sure exactly what therapies did to the brain. Well, we now know from lots and lots of research that's been done, especially in the past few years, that rehabilitation definitely, without question, 100% helps the brain rewire itself. We didn't know this before. We now know this for sure. So getting in early, getting the rehabilitation team involved, starting therapies reasonably quickly really does help the brain rewire itself, and that's very, very important. And so this is just a picture of a nerve cell, the nucleus of the nerve cell, the big round thing in the center, and nerves have arms called axons and dendrites that go out and hook up and connect with other nerves. We now know that rehabilitation can take nerves that look like the structure on the left and make them look like the structure on the right. In other words, nerve cells that are injured with rehabilitation can help grow new circuits and hook up connections with other nerves. Now, what we still don't know are things like how much therapy should we do? Does one therapy technique work better than another therapy technique? Should we do 3 hours a day, 5 hours a day, 5 days? We don't know that stuff for sure yet, but we definitely know that rehabilitation is important. And so, patients with significant traumatic brain injuries, we are going to recommend for sure some type of rehabilitation therapy. How do we know that rehabilitation works? Well, this is a picture of what's called a functional MRI. And without getting too technical, essentially what functional MRI does is you can have patients do a task, and while they're doing a task, take a picture of their brain with an MRI and see what areas of the brain are active. And clearly there have been many studies now that have looked at the impact of rehabilitation and show that with therapies, different areas of the brain start becoming active, taking over for parts of the brain that are injured. And so there's a lot of research going on, and most of our rehabilitation journals now have tons and tons of articles, utilizing the technique of functional MRI to show what rehabilitation is actually doing. Okay, so what do we have here? Well, at Memorial Medical Center, in addition to the excellent trauma service that Dr. Sutyak talked about, and our excellent neurosurgeons and other physicians that help, we have an inpatient rehabilitation program. Gotta wait for these things to pop up on here. So we are a 30-bed inpatient unit. We're interdisciplinary. We'll talk about what the different team members do in rehabilitation. We're very functionally focused, so we measure outcomes. We're part of a national, actually international data system that looks at our outcomes and compares them to other facility outcomes so we know how we're doing. As an acute inpatient rehabilitation unit, one of the requirements is that patients be able to do at least 3 hours of therapy a day. Most of our patients get 4 or 5. So at least in terms of the traumatic brain injury patients, the patients do have to be awake enough and alert enough and be able to participate in therapies before they come to our program. And again, we're part of an international database that compares our outcomes to others. We are a team, and there are many members of the team that work together, and hopefully in the best interest of our patients, to try to get them well enough to go home, re-enter the community, resume activities. It would be nice if everybody could go back to work and return to driving. Physicians, rehabilitation nurses. We'll talk a little bit about our different therapists and what they do. We have healthcare neuropsychologists that work on our unit that are very instrumental in our program. And then, as I always say when I give talks on rehab, the most important person on our rehab unit is our social worker, because they're the ones that liaison with families and really work on getting patients home and arranging all those services post-discharge that are so important for our patients. So I'm the rehab doctor. What do I do? Well, my responsibility for the patients that come to us with brain injuries, in addition to helping with goals and that kind of thing, is to really deal with the medical issues that occur on our unit. And there are a number of issues that are very common that affect patients with brain injuries. We deal with issues such as depression, and our psychologist helps us to help determine who may or may not benefit from medication. Spasticity or stiffness in muscles is a very, very big problem with our brain injury patients, especially those that have had that diffuse axonal injury that you've heard about. Brain injury patients get agitated, especially at night. That's a huge problem may limit people from going home or having a spouse be able to take care of them. And there are medications and techniques and things that we can do to help with that. Many of our brain injury patients have sleep disturbance. They're sleeping during the day, they're awake and agitated at night. Our therapists don't like to work at 3 o'clock in the morning. They want to work on a regular schedule. We have to get our patients back on some type of regulated sleep-wake cycle, and we have medications that help. Many of our brain injury patients have problems with bladder function. It's already been discussed that not only do patients have often with brain injuries, but have other injuries like long bone fractures or spinal cord injuries, and many of them have pain that we have to deal with in order for the patients to optimally participate in a program. Our rehabilitation nurses are critical in taking care of our patients. These are the people on our rehab team who spend the most time with our patients. And they're the liaison often between the patients and me to help identify what some of these medical issues are that we need to intervene with. And they deal with things such as bowel and bladder issues, skin issues. We try to avoid things like bed sores, and so our nurses have a program that they do to help minimize that. Our rehab nurses are very involved in educating patients and families for medical issues and things that will be important when they go home. And it's very important to me, the rehab nurses are the ones that call me when a patient has had a change in condition that might alert to something like hydrocephalus that Dr. Amin described, or an infection, something that's changed that would require medical attention. So they're the ones that call me with that assessment. That's very, very important. Our physical therapists, of course, deal primarily with the lower extremities, and their primary focus is on those mobility skills that I mentioned. Patients getting in and out of bed, patients transferring to a toilet safely, getting into a chair. We all want our patients to walk, so getting them up and getting them mobile are very, very important issues. We have some unique equipment in our program that our therapists use to help patients. We have, for example, the Proprioceptor 4000. This is basically a balance machine. Some of our patients with post-concussive syndrome who are here know dizziness is a very, very common problem following concussions, problems with balance. We have some specialized equipment that might help patients regain some of their balance and, of course, help with walking. And we have some equipment that would help with that. For our patients who are not strong enough to be able to walk on their own on ground, we have a partial body weight treadmill training program where patients are supported in a harness. They walk on a treadmill with the assistance of the therapists, and this can get people up on their feet and mobile earlier. Our occupational therapists deal primarily with the upper extremities, and they are going to deal with our activities of daily living that I mentioned. Patients bathing, dressing, feeding, grooming, toileting, the basic skills that they need to be able to do to go home quite often. And some specialized equipment. We have electrical stimulation apparatus for the upper extremity called the BioNess that the therapists will use with patients who have severe paralysis of arm muscles that may perhaps help regain function. We mentioned visual impairments, and our therapists have access to equipment that might help patients who have visual disturbances to help refocus and compensate and things like that. Our speech and language pathologists, very important in caring for our traumatic brain injury patients. Swallowing can be affected in patients with brain injuries. We've heard that patients often have facial fractures and skull fractures and things around the mouth that might affect their ability to swallow, and our speech therapists will help address that. And again, we've alluded to cognitive problems and issues with speech and language that are so critical. For our patients who have facial muscle paralysis and have difficulty swallowing, our therapists have an electrical stimulation apparatus called Vital Stim that helps stimulate the throat musculature and, again, may help patients regain the ability to swallow a little more quickly than they normally would. We're very fortunate in our program. Not all therapy programs have access to recreational therapists. We have a recreational therapist in our program who does an awesome job with our patients. She's the therapist that get patients back to doing recreational activities that are so critical. Golf and fishing seem to be the big ones, especially that our male patients like. Our recreational therapist will take patients on community outings, take them to a restaurant or someplace in the community to kind of help simulate what's going to happen when they go home and see how they interact in a social situation. We have a fishing clinic that our therapist does. We have a golfing clinic, and there are a number of other kind of specialized recreational type clinics and activities that they hold for our patients. And obviously these are very popular, and especially the golfing one. Because cognition is such a big problem in our patients with traumatic brain injury, our psychologists, our healthcare neuropsychologists, play a key role on our brain injury team. They do things like cognitive assessments and help design a treatment program with the speech and language pathologist to address those cognitive issues. It's not uncommon for us to have, unfortunately, young traumatic brain injury patients on our rehab unit. Alcohol, unfortunately, plays such a key role, as Dr. Sutyak mentioned, and we have too many young people. But often they're in school, and after they leave the hospital, there are issues about, can they go back to school? Can they handle classes? What do we do? And our psychologists can do those assessments to help, and then liaison with school faculty and administration to help get them back into a school environment. A lot of our head injury patients have problems with behavior, agitation, confusion, personality change, and our psychologists will help with behavioral programs. One of the big things we have is just coping. A traumatic brain injury is a major life-changing event, and it affects not only the patient but everybody in the family. How do patients and families cope with now a person being different? Our psychologist helps with that counseling. We talked about depression before being a common problem, and they're very good at letting me know when they think patients need to be started on a medication. Unfortunately, many of our brain injury patients have substance abuse issues, alcohol and drugs, especially as it relates to car accidents and ATV accidents, and we have a substance abuse team that works with our psychologists to help get involved with these patients. And then again, our social worker, who's so critical on our unit to helping organize things to get patients home. They start discharge planning really immediately upon arrival to our rehab unit, and where they're going to go and who's going to help. They help with the home environment, getting equipment for patients that they might need. And a big one is disability issues. Patients who have brain injuries, typically they're young, they often aren't going to be able to go back to work, especially our patients that come to an inpatient unit, and helping through that disability process, our social workers are critical. What about recovery? What do we tell our patients? How much are they going to get better, and what's the time frame? Well, the how much is hard to answer. We'll talk a little bit about prognosis in a second. And there's really no magic rule, but typically what we tell patients is in terms of motor function, what they're going to get back in a year, and in terms of cognition, it may take up to 2 years. Now, these are not hard and fast. There are a number of studies that, and our experience with our own patients shows that patients can improve well beyond 2 years. There's nothing magical about that. But most of the recovery is going to occur early. Are there any factors that help us predict how our patients are going to do from a rehab standpoint? There are a number of factors that help prognosticate. Age is very important. Young brains heal better than old brains. So a 21-year-old who's in a car accident with the same brain injury as an 80-year-old who falls down the steps, and the 21-year-old in general is going to have the potential to do much better than the 80-year-old. It's just in terms of those rewiring circuits and things, young brains have a better potential to heal. We know that patients that were good students, are educated, have good jobs, typically do better than people that don't. You're starting, I guess the theory is you're starting with better brain substance or more developed brain substance. Those patients do better. Substance abuse is a big negative. Patients that have a history of drug and or alcohol abuse, their prognosis after a head injury is not nearly as good as somebody who does not have a history of substance abuse. Dr. Amin talked about the Glasgow Coma Scale score. Patients, and this is intuitive, the more severe injury you have, the lower your Glasgow Coma Scale score is, the worse your prognosis is for recovery. Now, that's not to say that people that have low Glasgow Coma Scales don't ever get better, and that patients that have high Glasgow Coma Scale scores always have a fabulous outcome. But in general, the more severe your injury is up front, the worse you're going to do. And then there's this issue of what we call post-traumatic amnesia. Post-traumatic amnesia refers to if I have a patient and if I tell them something and ask them to remember it now, will they remember it tomorrow? That's what we call anterograde amnesia. Patients that have problems with that last for a long time tend not to do as well after brain injuries. So these are just a few things that we can look at when families are asking overall how we think people are going to do. Finally, there's just a number of community services that are available that we can help liaison patients with. We have our durable medical equipment companies that help get us the equipment that patients need for home. There's a company called Illinois Assistive Technology that helps with some kind of higher level, neat kind of things like communication devices and stuff like that. We do not have a formal driving assessment program here in Springfield. This is a big issue after brain injuries. Is someone well enough to go back to driving again? There are two formal programs that we send patients to. One's in Peoria, one's in Champaign, and they do an excellent job to kind of help take the burden off us with those patients that we're not really sure are safe enough to return to driving. We also have a link with vocational rehab program here in Springfield that can help us in determining whether patients may be fit to go back to work and those type of issues. Again, I mentioned before with our kids, we often will hook up with school programs, both at the high school level and college level, to kind of help transition patients back. Department of Rehabilitation Services is key. They can sometimes provide help for patients at home, and then there are a number of support groups. Again, brain injuries don't just affect patients, they affect families as well, and so there may be some support for them.